Welcome, everyone. Welcome to this very exciting and new session that we have at San Antonio, this conference called Translational Controversies. My name is Komal Jhaveri, and I'm a breast medical oncologist at Memorial Sloan Kettering Cancer Center. So in this session, this Translational Controversies session, we have 6 fantastic presenters here who will be providing new perspectives on 3 controversial topics within translational medicine. And unlike a debate, these speakers will not be taking a very strong pro or a con stance, but instead will be using examples and discussion to explore differing approaches. At the end of each presentation, there will be a brief Q&A.
I lost my glasses.
Why don't we first start with polling the audience? Can we have the poll, please? So our first polling question is MTD an optimal primary endpoint for drug development in phase 1 trials? Can we advance? Here, maybe. There you go. So you might be able to pull up a QR code on your phone. Actually, let's go back. Can we go back, actually? Thank you. So there should be actually a QR code for you to be able to vote on this, but if not, we can do a show of hands. So how many of you think is MTD an optimal primary endpoint for drug development in phase 1 trials? Folks who want to say yes, can you raise your hands? What about no? Okay. All right. So why don't we hear from our first set of presenters? We have Drs. Hope Rugo from the University of California, San Francisco, and Dr. George Shapiro from Dana-Farber Cancer Institute, who will be presenting the controversy around maximum tolerated dose, or MTD, and discussing if this approach should rest in peace.
Thanks very much. We don't have any microphones, I guess.
Yeah, that is weird.
What should we do? How do we
How about
present?
I don't know.
Hard to present without a microphone, but I don't think, maybe we can't present from our place, right? Okay. Yeah, I don't know.
It's working.
No, it's just you can't make the mouse move. Hold on. I will say that my glasses seems to have walked away, so let's see if I can see the slides. I don't have my glasses. Okay, so maximum tolerated dose, is there a better way, is my topic. Really, it was rest in peace. Let's see. The mouse is not working. I can't see the slides. What am I going to do? I'm going to let him go first. I can't see the slides.
Okay.
Because I don't have my glasses, and they're too far away. The slides are really far away.
Okay.
Jeff, you go first.
You want me to go first?
Yes. Why don't you go first? She's going to get
I'm
my
gonna get my
glasses.
computer so that I can see my
Oh,
slides.
you can't see.
No, sorry.
Let me get to the
Alright.
next stop first.
From the poll, it looks like I may have my work cut out for me. All right, so let's get the
Although I
slides.
have the slides now, so.
Oh, you do? All right, well, then we'll have Dr. Rugo go first.
I keep changing it, I know, sorry.
We're going to keep this very interesting as to whether the MTD should rest in peace or not. I think this controversy is very controversial already, as you can
It's
see.
controversial already. All right. Okay, now we'll go back and try again. Now we have microphone, I have the slides, everything is good.
It's all good.
Okay, so the NCI defined maximum tolerated dose, and it's actually interesting. You go back, this is now, decades old, as the highest dose of a drug or treatment that does not cause unacceptable side effects within a specific time period. And the idea here is that you determine MTD by clinical trials testing increasing doses on different groups of patients until you get the highest dose with acceptable side effects. So dose-limiting toxicity is generally defined during the first cycle of treatment, usually 4 weeks, and standard phase 1 trials use a dose escalation process, and there are a couple of different approaches generally used, and you get to where you have too many dose-limiting toxicities, and then you stop at one lower dose. So why is this a problem, and why are we discussing it today? Well, randomized trials use the MTD for registration purposes, and then the dose is translated into early-stage trials, but clinical trial populations often don't reflect the general population because we have strict eligibility. We've seen this, and that's the value of real-world population studies. And there's specific exclusion requirements that we don't take into account in when we're treating our patients in clinic. So there's no evidence to show that if you push the drug to its maximum tolerated dose that it will improve outcomes. And the challenge for the treatment of breast cancer is, of course, to optimize efficacy, but also minimize toxicity. And our goals of therapy vary depending on the setting. Do we really want to cause as much toxicity in the metastatic setting as we possibly can when we don't know that that dose is optimal? So how do we determine the optimal therapeutic window? This is, of course, quite difficult. The mouse is not working. I am really having a challenge. Okay, so how does MTD fail in clinical practice? Well, we have a lot of examples, and I've just chosen a couple here through the talk, but in capecitabine, we all know the problem here. Capecitabine was approved at 2,500 milligrams per meter squared in 2 divided doses. Does anybody in this room use capecitabine at that dose in breast cancer patients? No one. So at least no one was brave enough to raise their hand. So the issue is that now, we had that actually as the control arm for a few registration style studies, but there's complex pharmacogenomics here. We don't really even have a good way of measuring who metabolizes capecitabine well and intermediate level, and there's a lot of intermediate levels or not at all. So we start at 2,000 milligrams per meter squared. We know that the MTD that was defined is not the right dose for our patients. And we also use alternative dosing schedules because 2 weeks on, 1 week off is really not the best approach for many patients in terms of optimizing the therapeutic window and minimizing toxicity. We also have a problem with standard MTD approach that doesn't take into account chronic toxicities. And these chronic toxicities can develop after multiple cycles of treatment, and we don't get that. So that's not the way we test our agents. We look at the MTD over 1 month, but we know that some toxicities escalate over time, diarrhea, neuropathy, fatigue, and so we don't know what we're doing in that situation. And it's true for cytotoxic therapy, but also for our newer targeted agents. I'm not sure why this isn't working, but it isn't. The mouse does not work. Okay. Maybe it signals them, I don't know. So this is an example from a really nice publication in the New England Journal in 2021, examples of drugs whose doses and schedules were modified for safety after approval. So that gives you a good idea of why it is that we need to rethink this whole approach. Do we really want to treat, what did you say? Don't use the mouse. How do I move ahead? I say next slide? Okay, got it. Apparently, next slide is the right way to go. So, and in this situation, we've treated a whole lot of people in registration studies who've gotten toxicity, and then we have to modify it after approval. So that's obviously not the optimal way. And you can see that there's a number of agents here, not specifically for breast cancer. In fact, none of these are, but there are a number of drugs which have had modified schedules, changed doses, and the reasons are listed on the right-hand side of your slide here. And it's actually a very nice article talking about how we can potentially rethink our approach to maximum tolerated dose. Next slide. So there are special situations we also are dealing with that challenge maximum tolerated dose. Targeted agents, biologic therapies, antibody drug conjugates, big topics at this meeting. And standard MTD dosing, we may get unwarranted toxicity. And basically, the efficacy needs to be decoupled from the maximum tolerated toxicity. And the delivery of the payload from an ADC is impacted by multiple factors. And we're all now very familiar with this idea of a bystander effect. That really doesn't have anything to do with the MTD. So our new approaches include preclinical modeling for optimal dosing. Using pharmacokinetic and pharmacodynamic modeling has existed for a long time. It's just that generally people don't attach those modeling tests to the clinical efficacy. And then receptor engagement may be an option for some of our antibody-based treatments, and then downstream biologic markers. We also could use a couple of different approaches. So you could look at alternative doses and schedules. Should you do that in phase 1 or phase 2? So maybe in phase 1, you have 2 paths where you're evaluating the drug, and then in phase 2, you can test both of those next to each other to understand not just the efficacy, but also the associated toxicity. It doesn't do any good to take a drug where 30% of the patients have to stop due to toxicity, or 50% of the patients dose reduce. So what are the risks of taking this approach? Next slide. These alternative approaches, next slide. In looking at a parallel evaluation of alternative dosing and schedule, include the risks of abandoning an effective drug. So if you were really stopping way below the MTD, maybe you have a drug which doesn't work as well at a lower dose. And we'll have actually an interesting example of that at this meeting, which I'll talk about in just a moment. You're treating patients with ineffective doses when you're doing this, and that's unfortunate for patients because, which physician, which patient wants to use a drug that doesn't work just to be a test in a trial? So we know that that's part of this risk. And then there's a higher cost and longer time to drug development, and that's a big issue for our patients and for our partners in the pharmacology industry. We want these effective drugs for our patients in the clinic. So what's the right endpoint for a standard MTD approach? So is a response rate the right endpoint? Is duration of response the best? We use response a lot, but what really matters to us is whether that response is durable, and we see that now in these spaghetti plots that are shown, which are very, very helpful. And we test drugs in phase 1 in advanced refractory disease. This disease we know is more resistant to therapy, so then you might need higher than necessary doses in a phase 1 dose expansion. You don't need those doses if you're treating patients who are naive to therapy or earlier in the course of treatment. And then, of course, we're using these doses then, and we move them into the curative setting. In the metastatic setting, where the drugs are approved, we want patients to live as long as possible with the best quality of life. And we can't necessarily achieve that with a toxic drug that may be given at a higher dose than is necessary. Next slide. So novel approaches in phase 2 trials use these several dose levels and schedules when indicated. The other approach, which hasn't been very popular, is intra-patient dose escalation. Starting at a lower dose and then escalating as tolerated may be another way to explore different doses. You could validate the drug dose and the schedule in the neoadjuvant setting, where we're using a number of drugs that have already shown efficacy, where we have enough data to know that it's safe. And then you could use intra-patient escalation to avoid ineffective drug dosing. So another question, of course, is if you do dose reductions and escalation, should that be individualized based on tolerance? Is that our pharmacodynamic marker? And then for antibody-drug conjugate, it's not just the payload and it's not just the antibody. What's fascinating when you think about the TROP2 antibody-drug conjugate, datopotamab, and then TDXD, right? These are 2 different antibodies, 2 different targets, same payload. One drug causes stomatitis and not a lot of ILD. The other drug causes more nausea and a little ILD. So same payload. So we know that the delivery mechanism still is not very well understood and is at least part of the antibody, not just the drug to antibody ratio, and the linker. So additional examples, CDK4/6 inhibitors. We've seen dose reduction studied in multiple trials, this big topic at this meeting, and it hasn't impacted efficacy. But is this an individual pharmacodynamic marker? If you don't tolerate the full dose and then you reduce the dose, maybe the patient who does tolerate the full dose needs that for efficacy. And that's something that's very interesting. I'll encourage you to hear the presentation of the Amelie study of 600 versus 400 milligrams of ribociclib with endocrine therapy. And in the abstract, you can see there's a better safety profile for some, but not all of the safety issues associated with the drug. So you may not be getting rid of all of the toxicities by reducing the dose. No difference in discontinuation for toxicity because the patients who tolerate 600 tolerate it pretty well. The approach of reducing dose in the face of toxicity, this in vivo test of pharmacodynamics, I think might be a way to get rid of MTD in the long run. And alpelisib, what's the risk? We saw in our trial looking at SOLAR-1 that if you gave a dose under 250 milligrams, the dose is 300, that you might have less efficacy. So that's an important part of understanding MTD. So dosing in the era of targeted therapies, phase 1 trials at MD Anderson, 24 consecutive trials treating 683 patients. You might argue 2004 might not be our era of targeted therapy, but they were using targeted therapy in 98% of the patients, and there was no difference in efficacy due to dose. But when they looked at the high dose group, there was increased discontinuation due to toxicity. So kind of another lesson. And then we'll just close talking about this patient-centered dosing initiative. This focuses on metastatic breast cancer, where again, our goals are a little different than an early stage setting, and we really do want to try and optimize quality of life while also improving response to therapy, symptoms, and length of life. So this was started by Ann Loser, the founder, and a group of advocates got together and then asked a group of physicians to serve as their advisors. And it's just incredibly impressive what Ann and this group has been able to do. Very, very, I think, important for all of us to understand what the power of this group is. And so they actually did a survey in over 1,200 patients. In a 2-week period, 1,200 patients responded to this, so big issue. And basically, most people had had a bad side effect from their treatment. They didn't always discuss it with their physician. And basically, you can see in the bottom, a lot of them didn't inform their providers about a bad side effect because people are afraid to not get the treatment. And in a subsequent survey, we had 114 physicians, kind of a sad story for MDs responding versus patients, in the spring of 2021. And what we saw actually was that most people don't believe that the higher dose is better, more effective than a lower dose. And almost everyone was willing to discuss dosing options based on patient attributes and patient goals. And then we looked at different drugs for which lower doses were prescribed and also oncologist reasons, which was really fascinating. So the bottom line is it's critical that trials that evaluate new, can you go to the next slide? It's very hard, sorry, because, yeah, the slides are not working. Can you go to the next slide? Thanks. This is the patient-centered dosing initiative, talking about the different, the reporting of bad side effects. And the next slide. And then this is actually very interesting, but unfortunately is missing part of it. Must be due to this issue we're having with the computer. But basically the percent who do not believe that a higher dose is always more effective than a lower dose. And then the percent who would be willing to discuss dosing options based on patient attributes is what for some reason is missing there. That was 92% for patients and 97% for oncologists. So in the metastatic setting, we have a lot of flexibility. And the bottom curves are really looking at where oncologists' reasons for starting patients on a lower dose and drugs for which starting lower doses were prescribed. So it's quite common that we actually start low in clinical practice. So next slide. The bottom line is that it's critical that we, go to the next slide. It's critical that trials that evaluate new agents carefully evaluate optimal dose and schedule outside of simply escalating until there's intolerable toxicity, particularly in patients with advanced and refractory cancer. We should be able to optimally decide on our dose by using the neoadjuvant setting for patients with early stage disease. We need a lot of work to understand the best way to do this, and you'll hear about some of that work from my colleague, Dr. Shapiro, who'll talk some about the Optimus trial as well, to see how we can move forward in this area. Thank you.
Thank you, Dr. Rugo. Sorry, we're having some glitches. Dr. Shapiro, thank you.
I have a number of animations on the slide, so you're going to have to click through quickly for me. All right,
Thank
well,
you.
let's go ahead. I'm not really going to argue with anything Hope said. I don't think it's feasible to argue in this day and age that MTD should be all that we can do. Clearly, we have to dose optimize. I think one major question is when, and really whether MTD should truly rest in peace. I guess my answer will be no. Next slide. Oh, can I control it?
All
Oh, there we go.
Success.
All right, so as Hope
Okay.
indicated, this is
Now
the
it's gonna be
traditional dose
fixed.
selection strategy, either a 3+3 design or now Bowen designs, get us to an MTD where get us to the point where we have dose-limiting toxicities, and then the dose below would be defined as an MTD. This may be taken forward into phase 2 and ultimately registration trials where the MTD is compared to a standard treatment. And for molecularly targeted agents,
Or not.
all right, there we go. For molecularly targeted agents or even immuno-oncology agents, this does present some problems. The MTD may not be needed or required. Treatment may be many, many months and years, and we're only defining DLTs during a very short observation period. And long-term tolerability may be affected by chronic grade 1 and 2 toxicities in these treatments where the dosing is often continuous. So what is the concept of formal dose optimization that the FDA wants us to think about? So this involves randomizing patients between 2 or more dose levels. It mandates using the totality of the data, including safety, PK, occasionally PD, and efficacy to choose a dose. And the goal is to establish the lowest dose that is both safe and effective. And the press is to perform this dose optimization very early in the drug development process. And the question is, how broadly should this be applied? And is early dose optimization always serving public health interests? And although MTD alone probably should rest in peace, traditionally determined MTD or recommended phase 2 dose, I would argue, still has value. So here's one way to think about this as very, very early dose optimization that would occur in the context of a dose escalation trial. And in this view espouses that we shouldn't really think about the concept of MTD at all. What we should be defining is a minimally reproducible active dose. So what in practicality would be the strategy for doing that? This would be if you're at a certain dose level and there's neither efficacy nor toxicity, one would escalate. If there's efficacy with acceptable toxicity, one might expand, but one could at the same time escalate or even look at a lower dose level. And of course, if there's efficacy with unacceptable toxicity, we would then de-escalate. So here's an example. This is from the lung cancer world, where this was approximated, this method of dose optimization. So this is osimertinib, the EGFR mutant selective kinase inhibitor that affects not only activating EGFR mutations, but also the T790M gatekeeper mutation. So the dose escalation evaluated several dose levels, and then if there was any efficacy at any dose level, what happened is that dose level was immediately expanded, and then additionally there was concomitant escalation with that expansion. And so you can see at the bottom left that multiple dose levels were evaluated, but the efficacy looked very good at 80 milligrams twice daily and above, and really didn't get too much better as you moved above. And then if we looked at toxicity in these expansion cohorts, what happened is that as you got above 80 milligrams, at the 160 and 240 milligram doses, one was getting toxicity more consistent with wild-type EGFR inhibition, more dose omissions and reductions were occurring. And so this totality of data then allowed them to define what would be a minimally reproducibly active dose, which is how 80 milligram twice daily was chosen. Now, what are the challenges of defining a minimally recommended active dose for most drugs? So this type of strategy might work in a mutant selective kinase inhibitor in a homogeneous population, but it's not necessarily applicable to the development of most phase 1 agents. So first of all, we need to ask, what is an active dose? Now, Hope mentioned that we might be able to use some pharmacodynamics here for biologic activity, but the truth is that most pharmacodynamic biologic markers are not validated enough to be correlated with clinical benefit during early dose escalation. So one has to use tumor-related parameters such as tumor size, tumor markers, or ctDNA. And that means that cohorts are going to have to be large enough to assess activity and clinical benefit. And so that's what happened in the osimertinib study. There were multiple large expansion cohorts. And as Hope mentioned, enrollment of traditional phase 1 populations makes it very challenging to define a minimally reproducibly active dose during very early drug development. Patients may be more heavily pretreated. They may have a greater number of comorbidities. The patient populations are typically heterogeneous that we're enrolling in phase 1 trials. And patients may have more advanced disease and are not optimally selected for clinical benefit. And additionally, as toxicities experience evolves with novel agents, we learn how to manage those better so that we can ameliorate toxicity, and therefore doses that may initially seem inappropriate may become tolerable as we learn how to deal with them. So these considerations all suggest that optimization may be more meaningfully done during later stages of drug development. So what do we mean by later stages? So this is what the FDA is talking about. There we go. So we might work up to an MTD. Again, we don't need to abandon the MTD concept, but then, as Hope was saying, we would dose optimize and we might compare the MTD to a lower dose level and then use that totality of data to decide what goes forward in a registration strategy. So here's an example of that with trastuzumab deruxtecan. So maybe you can just flip through the bullets, but this worked up in the original phase 1 study to 8 milligrams per kg, this was a drug that had activity across dose levels. And what happened was that there were more toxicities above 5.4 and 6.4, so that was thought to be the range where we're going to have a recommended phase 2 dose. So what happened then was optimization occurred. There were 3 dose levels that were randomized, 5.4, 6.4, and 7.4, based on pharmacokinetic ceiling. 5.4 and 6.4 were actually looked at further, and then there was modeling of the exposure to efficacy and the exposure to toxicity that allowed choice of the 5.4 dose moving forward in further studies. So for experimental treatments entering phase 1 studies that have a high degree of efficacy with improvement in patient outcomes in homogeneous populations, maybe early optimization, such as this early randomization to a few dose levels before choosing a dose to go forward, is reasonable. However, this is not just always the case. Sorry, this is really hesitating on me. So there may be agents that have efficacy in several populations, but they may actually require multiple optimizations that are compared to the MTD. So let's take a drug that's in development right now that may pose some quandaries. This is the PARP1 selective drug, AZD5305, and this has activity across the dose levels that were initially studied. And it's clear that pharmacokinetically we achieve levels that are above what we need to have efficacy based on preclinical modeling. In additionally, all the dose levels show very good pharmacodynamics, as shown by this correlation assay. And there's also very good tolerability across dose levels, as shown on the next slide, where there's very few dose omissions and reductions. So when should the optimization take place? So you might want to know, where should you expand all these dose levels going forward very early on? It may be that higher doses may provide greater durability, and only response rate may not be the only measure. And we may have to have different optimizations in different populations. For example, this may vary by disease type. This may vary by homologous recombination repair deficiency mutation or other mutational backgrounds. And so it may vary in the PARP inhibitor sensitive versus PARP inhibitor resistant state. And so it may be easiest to optimize after an MTD is already established. So just one more minute. I know we're getting late. So what about when efficacy is not as clearly established in early phase trials? So this is an example of CDK inhibitor development that Hope mentioned to you. So what would be proposed by the FDA now with dose optimization is on the left. You might work up to an MTD of a CDK inhibitor, and then you would randomize that MTD to a lower dose, decide which one might be the better going forward, and then bring that forward into phase into registration trials, as opposed to what was actually done on the right, which was working up to an MTD, then actually doing the registration trial, comparing the CDK inhibitor with fulvestrant to fulvestrant alone, and then maybe going back later and optimizing later. So which randomization should be first? Should we take the MTD and endocrine therapy versus a second dose with endocrine therapy? Or should we take the MTD and with endocrine therapy and randomize to endocrine therapy? In addition, there's even another strategy that could be used that would actually take the MTD with endocrine therapy, the lower dose with endocrine therapy, and randomize that to endocrine therapy in a registration 3-arm study. So I would argue, you've got to click forward twice for me. I would argue that what we originally, can you give me one more click there? I would argue that what we originally did may be okay. And why is that? And here's the last slide, Komal. So here's the rationale for why we would use the MTD with endocrine therapy versus endocrine therapy first. So the treatment becomes available while we're awaiting the results of the dose optimization. So obviously this affected millions of women worldwide. The selection of the dose may not necessarily be a small trial. So we might actually have large numbers of patients that are not exposed to a CDK4/6 inhibitor if the CDK4/6 inhibitor was not going to produce clinical benefit. And in a 3-arm trial, it may be longer to determine clinical benefit of the high dose when that is actually the one that works. And in a 3-arm trial for an intervention that may not be effective, we're actually enrolling twice as many patients to the experimental arms. We also have to consider that in the examples that we've chosen today, there's been good efficacy of these drugs. What about the vast majority of phase 1 agents that ultimately do not show efficacy? Should we, in randomized trials, should we really be optimizing these early? So considering that many phase 1 agents do not produce clinical benefit or have challenging efficacy readouts in phase 1 populations, early dose optimization may expose very large numbers of patients to ineffective treatments. So therefore, I would argue that MTD can't work alone, but certainly it should not rest in peace.
Thank you, Dr. Shapiro and Dr. Rugo. So given the unexpected challenges we faced, I think we're going to optimize this session and just move on to our next presenters. So let me have Dr. Angela DiMichele from the University of Pennsylvania, and then we'll have Dr. Sean Cozen, research affiliate, Massachusetts Institute of Technology, and they will be discussing the controversies around randomized clinical trials versus real-world evidence.
Great, thank you. So it's great to be with all of you today. Sean and I actually, I think, are not really taking two sides here, but in fact, we think that this title should be Real-World Evidence and Randomized Trials, because we really need both. Let me see how this doesn't work. So next slide, please. So we know that standard randomized clinical trials have served us incredibly well. The safety has been well established before we get to phase 3, so we rarely see unexpectedly severe side effects emerge. We're able to isolate effects of a new intervention and be able to tease out additive or synergistic effects because we have a very uniform population of patients. Importantly, confounding of measured and unmeasured confounders are balanced between groups through randomization, and we can adjust for differences and measure interactions. We also have the ability to quantitate the role of chance in actually finding the results that we found. And then importantly, this is a common language and process. So what we do is understood by the scientific community because we follow a set of rules and we protect patients from harm to the extent possible through all of the regulations that surround those rules. Next slide. But we know that randomized trials have failed us in some very important ways. As you've heard said so many times at this meeting already, they can be a poor reflection of the real world because we're limited by the stringency and eligibility criteria in order to apply our standard methodology. We also lack diversity in medical conditions, in patients who have less than perfect organ function, and importantly, in geographic, racial, ethnic, and social factors that really reflect the richness of each patient's unique biology. Further, we can end up with incorrect assumptions that derail the interpretation of the results. We have to make these assumptions up front, but if we're wrong, the trial data may be unable to answer the question definitively. This wastes resources and in fact questions the ethical issues around enrolling patients in a trial that just is poorly designed and isn't going to be able to answer the question. And of course, they're time-consuming and have high cost. Next slide. I'm going to move forward a little quicker because I know we have a lot to get through. So, next slide. Doesn't want to go. So, how can real-world studies help us overcome shortcomings? By providing more diversity, by enlarging the sample sizes, by uncovering the true toxicity and tolerability of a drug, by allowing us to assess that tolerability in the context of other medical conditions, by allowing us to generate comparisons with a wider range of alternative therapies, and by enabling us to validate benefits seen in randomized trials to determine whether they actually occur and are bigger or smaller than determined in the trial. Next slide. It's not going. Okay, so I just want to give a brief example that we're all, many of us are grappling with right now, which is this issue of palbociclib and overall survival. Just to give you historical context, the initial accelerated approval of palbociclib in the first line with letrozole was back in 2015, and it got regular approval beyond the first line with fulvestrant in 2016. But we were waiting for the final analysis of the first line data. That came in 2017, and that led to regular approval in combination with letrozole. There was an approval for male breast cancer with real-world evidence in 2019. But we were waiting on the overall survival data from the first-line trial, Paloma 2, and actually the investigators knew that this trial was going to be underpowered for overall survival. So Pfizer approached us at the Penn Center for Innovation, and we began collaborating with them on real-world evidence to see if we could determine, using real-world evidence, what the true overall survival analysis would be comparing letrozole to letrozole plus palbociclib. And I just want to briefly show you those results, if I could go forward. Let's go past this. And so here's the first study we did. This is from Flatiron data with a little over 1,400 patients and 24 months of follow-up. It isn't important for you to look at each one of these curves. This is how we do real-world analysis by doing several different types of analysis that enable us to try to balance the two groups that we're looking at. What I want you to focus on is the consistency of the data across these different analyses. Take a look at the one in the middle, the IPTW, where we saw in the investigational arm, the palbo plus letrozole, we had not reached the median overall survival, but we saw 43 months in the letrozole alone arm for a hazard ratio of 0.66, so that was highly significant. There was a second analysis, let's go to the next slide, because that was a relatively short duration of follow-up and a smaller sample, so we went to a larger sample, longer follow-up, and what you can see is great consistency here. Again, we are seeing that there is a benefit to the addition of palbociclib to letrozole over letrozole alone, an overall survival benefit with hazard ratios in about the 0.67 to 0.76 range. What I want to point out to you here, though, is look at the control arm. In this study, it was about 43 months. Now here, sorry, can you go to the next slide? So here are the data now from Paloma 2. On the left was the overall survival analysis we saw at ASCO earlier this year, only 666 patients, and there was no benefit to adding palbociclib to letrozole in overall survival. I think there were three main problems here. Number one, it was an underpowered study. Number two, the control group had an overall survival of 51 months, much greater than what we saw in the real-world data and greater than what the investigators had planned when they designed the trial. And finally, there was missing overall survival follow-up, and it was differential and greater in the patients who had been on the control arm. And so this created a conundrum. How do we adjudicate the understanding of overall survival between this real-world data and the clinical trial data when we know the clinical trial had problems? Is the real-world data the solution? Next slide. It is not, because there still is selection bias and confounding that we just cannot control when we're looking at data in the real world. We also know that we have limitation in our data sources. And as many of you know who take care of patients, if we're using EHR data, that data is not designed to be used for research. And so we are doing everything we can to go into that data and come up with robust understanding of what we're seeing, but it's never going to be perfect. Next slide, final slide. So where do we go from here? I believe we need to use these in a complementary fashion. I think we should use real-world evidence as part of drug approval to really confirm that our trial findings are true when we use the drug in the real world in different populations. I think importantly, we need to educate the public about the need to allow health systems to collect and share data for this type of research because it is to everyone's benefit. And finally, I think we need to overhaul the EMR system so that we get data that we can really use for research. One source is one such system that could allow us to use these data that we generate in everyday practice to be able to answer these questions. And finally, I think the FDA is really here partnering with us to help us figure out how to do this. I'll turn it over to Sean.
Thank you, Dr. Dimishra.
Great. It's great to be here. I have to say, as a thoracic oncologist, it's a bit intimidating to be at a breast cancer conference, but so far everyone has been quite welcoming, and hopefully that's not going to change after my presentation.
Easier. Scroll up. Yep.
Oh, there we go. My disclosures. Okay. So, obviously, this is a session about real-world evidence, and real-world evidence has been getting an increasing amount of attention lately, which makes one wonder, why is real-world evidence so important? And I think one way to answer that question is by looking at what defines an ideal clinical trial. When we design a clinical study, ideally we shoot for a design that has an appropriate balance between internal and external validity. As we all know, external validity is critical to be able to generalize the results to patients at the point of routine care, i.e. real-world patient populations. Unfortunately, what has happened over the years is that we focus too much on internal validity at the expense of external validity. So the majority of cancer clinical trials today lack external validity. They have an external validity deficit that can be mathematically, in fact, quantified. And it's that deficit that we are trying to address with real-world evidence. There are many reasons behind why this external validity deficit exists. Here are some major ones. There are differences in protocol-specified procedures and routine care. The way we treat patients in clinical trials is fundamentally different than how we treat patients in the real world at the point of routine care. A narrow eligibility criteria that was mentioned previously. We exclude patients who have a poor performance status, organ dysfunction, brain metastasis, comorbidities, you name it. And also inadequate access to clinical trial participation, especially among underrepresented and socioeconomically disadvantaged groups. The same reasons, the same factors that are involved in lack of access to healthcare resources are at play when it comes to lack of access to clinical trials. So patients enrolled in clinical trials, especially in oncology trials in the advanced stage, can be fundamentally different than patients in the real world. And one of the problems that this deficit creates, external validity deficit creates, is that the current body of clinical evidence derived from conventional clinical trials can be inadequate to inform patient-specific treatment decisions at the point of care, especially for underserved patient groups. And unfortunately, guidelines do not generally address that. And this can contribute to health disparities and experimentation by clinicians at the point of care. There is evidence in support of this, in fact, coming from real-world evidence that tells us that outcomes of patients in the real world are inferior to those observed in conventional clinical trials. Here's one example where we used Flatiron data to look at patient outcomes in metastatic non-small cell lung cancer treated with PD-1 inhibitors in the first year following the FDA approval of these therapies. In this case, we looked at nivolumab and pembrolizumab. And the bottom line here is that what we observed, the median OS was lower than what we had observed in the corresponding clinical trials in support of the approval decisions at the FDA. So in the absence of real-world evidence addressing external validity deficits of specific studies, treating physicians have other options. They can use mathematics to adjust the results of conventional studies to be able to treat the N of 1 that is sitting in front of them in the exam room that can, again, be fundamentally different than the average treatment effects that we derive from conventional clinical trials. And I'm going to go over this very quickly in the interest of time. My colleague, Roger Stein, who's a professor of data science at NYU, a couple months ago published this methodology where our intention was to provide a decision tree to help clinicians and also clinical investigators adjust for the external validity deficits that exist in conventional clinical trials. Just very briefly, we took the mathematical concepts and probability calculus and translated those again into decision trees that we hope clinicians can use without any expertise in data science or statistics. So randomized clinical trials, we're not saying that they're not useful. In fact, they're quite important for controlling for alternative explanations of treatment effects or the unknown unknowns. But unfortunately, our clinical trial enterprise is critically flawed and leading to results that are not generalizable. But in cases where we know the patients we're treating through precise characterization, randomization may not be needed. In fact, it may not even be ethical. FDA knows this quite well, and here's an abstract from the FDA presented at ASCO last year that they approved 153 new indications from 2001 to 2020 based on results of single-arm studies in advanced metastatic setting. And what's interesting here is that a third of these approvals were actually regular approvals. So regular approvals based on single-arm trials are possible when you characterize the patients precisely. And the response rate was used as the endpoint in the majority of the cases, 80%. Durability of response was supportive evidence. And here is just a historical look at other cases where FDA has used data from single-arm studies to make approval decisions. So I'm going to, in the interest of time, very quickly go over the rest of the slides because characterization of patients, I think we have a lot more room to go. We started with anatomy, lung cancer. There's a lesion in the lung. We call it lung cancer because anatomically that's where it is. Reason being, surgeons used to take care of cancer patients before they were medical oncologists. And then we brought histology and then genomic sequencing with single driver mutations that have reached their limit. But now we need era of multi-omic and composite biomarkers, and we can use artificial intelligence to develop a new category of biomarkers called digital biomarkers. This is a paper we published when I was at the FDA. I'm not going to go through the details again in the interest of time, but digital biomarkers are now, as of last year, a sanctioned category of biomarkers emerging from software as medical device solutions that are backed by AI. So I was going to give an example of a digital biomarker that successfully subdivided malignant mesothelioma into several different subtypes. Histologically, we only have 3 subgroups in malignant mesothelioma. But in the interest of time, I'm going to skip that. But for those interested, the reference is there. So AI, in cases where the human visual inspection is volatile, a great example is something that has been discussed in the past couple of days a lot in patients that are HER2 low. We saw that there was major discordance among pathologists, up to 60%, in determining what's HER2 low. This is where AI and digital biomarkers could be quite effective. Thank you.
Thank you, Dr. Kozin and Dr. DiMichele. We'll move on to our last set of presenters. We have Dr. Nadia Harbeck from the University of Munich and Dr. Torsten Nielsen from University of British Columbia, and they will be discussing the controversies around Ki-67 testing.
So thank you, Kamal. Thank you to the organizers for giving us those 15 minutes to complete our talk. And I have to disappoint you all. We're not going to have a controversy, even though we have a pathologist and a clinician, because we've resolved the controversies in these transatlantic phone calls for the last couple of weeks. So scrolling doesn't work. Okay, so there is, Ki-67 is an immunohistochemical marker. It's easily determined and it's very inexpensive, and there is an undisputed prognostic impact as shown by Dr. Diazambuya very early in his career probably. But the frustration from us clinicians probably comes from the fact that there is no single cutoff point which actually tells us what to do with our patients if you just measure it once. And this was nicely shown by Carsten Denkert for the outcome as well as for PCR. So why this rekindled interest? Why do we have this session right now? It's probably because the FDA put Ki-67 into the abemaciclib approval. And with that, I rest my case and turn over to the methodologist.
Yes. Thanks, everybody. I'm Torsten, a pathologist from Vancouver, and I'll try and be extra brief, but extra interesting, I hope. Short version is the International Ki-67 Working Group has spent a decade plus trying to standardize this, and we had a paper last year. Please refer to it or find me at my poster tomorrow morning if you have extra questions. Ki-67 is a really interesting protein for measurement. It has lots of favorable characteristics biologically and immunohistochemistry that mean out of the thousands of proteins that are associated with replication, this is a good one to measure. But that being said, it's still problematic. We get a lot of disagreement when we had a lot of variability in the assay. Next slide, please. Which we were able to identify is caused not so much by staining, but by different interpretations by pathologists. They can agree with themselves, but not with each other very well. Next slide. So we could resolve this with attempts to standardize with calibration exercises with online digital images. Next slide. And we developed also an app that's publicly available. There's a nice little counting support device to help you get the counting done quickly and get hopefully accurate results. Well, not hopefully, we have data, next slide, that if you go to this effort, you can massively improve agreement. So interclass correlation is a measure of the amount of variability that's biology differences, what you want to measure, as opposed to noise in the assay. So we got rid of almost all the noise in the assay, even on core biopsies and full face sections, going to this effort, but it takes time. Next slide. You can do this more quickly if you do digital imaging, but I would want to point out that the trained eye, which has gone through this calibration exercise and put effort into it, can perform as well as a machine. Next slide. That being said, there's still residual variability in the assay such that we can only be really confident you have a low Ki-67 or a high Ki-67 if you're under 5%, over 30%, which are our conservative recommendations around needs for gene expression. And right in the middle of that area of peak variability, if you will, next slide, is 20%, which is the cut point that was chosen in Monarch E. So the Monarch E trial had a companion diagnostic, and that led to a conditional FDA approval in the US and Canada based on Ki-67 20% cut point. The supporting information has been published now. Next slide. And going through it, I want to commend those involved in that study for the excellent effort they did into standardizing scoring, into developing a detailed checklist of the conditions and controls that prove that it is robust for staining. Next slide. Unfortunately, the standardization of scoring has a lot less detail. It's based on just 3 pathologists who took eyeball estimates in 5% increments. The way they did their stats mean the true variability is really largely hidden. Next slide. And their bottom line recommendation that you could just do this in the context of your past experience and best judgment is very convenient and quick, but is extremely unlikely to hold up if you roll this out generally. Next slide. I would say, though, there's some big points of agreement that the handling guidelines from ASCO-CAP that were developed for ER and HER2 standardization certainly apply, that you need to set a very low threshold for brown in an invasive cancer nucleus to be consistent. that you need to train and calibrate on standardized images, and you shouldn't count hotspots. You should attempt to average across the material available to you to assess. Next slide. Despite that, there's some significant problems with implementing this that I think the pathologists around here will have faced. One is that the approval for the abemaciclib adjuvant indication was based on one particular device, which only about 2% of labs have, and your hospital lab isn't going to spend hundreds of thousands of new capital equipment and re-optimize all of their immunostains just to do this assay. So in real life, everyone is going to be off-label. These are going to be LDTs that are being used. Next slide. So what can we do about that? Well, bridging studies. I think Sunil walked back in. He just published this bit of work, which is one attempt to move to another platform, and a little bit less agreement, but still pretty good. Next slide. Really, though, the solution is external quality assurance programs. So College of American Pathologists is working on this. My colleague David Rim has developed a tool to help with this with some ground truth Ki-67 values. Next slide. But that's more about staining. As I mentioned, scoring is the bigger issue. And if you take a method, for example, the Swedes had a method that was internally validated and they thought was really good, and they applied it nationally. But when you followed that out for 5 years for its performance across tens of thousands of breast cancers, different hospitals' mean scores were varying between 15 and 30%, huge differences. Next slide. And so their solution is actually to move to the IKWG method that was developed by a group including Swedes and Danes, among others. But you can also do this with image analysis, and there are publicly available free software that you can use, some of which our group has published on. Next slide. My last point, though, is even if you do all this and you get an internally precise test, you go to that effort, there can still be set point biases, and the way you need to benchmark your own system against the images that were used and the calls that were made in the original trial, and that can only be done if the images are made available. So I would encourage that to be the case for research in this area. Next slide, and my last slide. For all of the things I said there, bottom line is if you have a validated scoring system and QC programs in place, you can have a robust analyte here with Ki-67. You can be pretty confident of really low and really high scores, bearing in mind it is a continuous variable and probably is best interpreted in the context of other clinical factors, relative differences before and after, and with caution, you can apply for fixed cut points, such as some others of importance that Dr. Harbeck is about to tell you about.
Okay, so how are we going to use this marker now in clinical practice tomorrow? So during the pandemic, we pooled large data sets, a couple of thousand patients from Mitch Dowsett's group, from Matt Ellis's group, from our ADAPT group, and just developed a simple algorithm in the luminal breast cancers, which patients we could keep on endocrine therapy before surgery longer if the surgical capacities weren't there in several countries. So, and for all we needed was ER, PR, Ki-67 at baseline, and Ki-67 as a dynamic after 2 to 4 weeks of endocrine therapy, and that actually worked very well and was helpful to a number of patients. So very inexpensive markers and quite clinically useful. So the response of Ki-67 to short-term endocrine therapy has actually been used in drug development for quite a time. And if you go back in time, you can see that short, small neoadjuvant endocrine trials actually predicted large trials, like the IMPACT trial predicted the ATTACK trial, and so forth. So this is a very robust biomarker, and our English colleagues actually have taken that forward to the POETIC study, where they looked in postmenopausal patients, 2 weeks of endocrine therapy before surgery, and if the Ki-67 dropped to 10% or less, that was called an endocrine response. And you can see that those patients who had this endocrine response, they did really well. And a number of these patients, mostly also the older population, did not have any chemotherapy. So we took this even further and combined it with Oncotype in all-comers populations, so pre- and postmenopausal patients. And you can see if you give like 3 weeks of endocrine therapy in the ADAPT trial, and everybody who had a Ki-67 of 10% or less and not more than 3 involved lymph nodes could forego chemotherapy based on the data from our English colleagues and the EXOC study group. So, and what we saw was that actually this worked. This is 5-year data from the ADAPT trial, distant disease-free survival. If you combine oncotype up to 25 and up to 3 lymph nodes together with endocrine response, you can see that whether it's pre or postmenopausal patients, these patients have excellent outcome just with endocrine therapy alone. So this nicely complements the data we saw on Tuesday from the TAILOR-X and from the RxPonder trial, where we tend to overtreat a lot of young women with chemotherapy. So it's quite a useful marker. The drawback was that in ADAPT, we only used like tamoxifen in the young women. You can see you only have a 40% endocrine response probability, which we validated in the first about 2,000 patients from the ADAPT cycle trial and showed at ESMO just recently. In postmenopausal patients with AI, you have about an 80% chance of endocrine responsive tumors. But the interesting thing is that in ADAPT, we also had patients, young patients with GnRH plus AI, and you can see in the green curve on the right-hand side of the slide, green bar, that they had the same endocrine response probability as the postmenopausal patients. So this is something to keep in mind and probably can be quite useful for these younger patients. So going back to Monarch E, why did the FDA choose the 20% cutoff for the label in the US, which by the way is not in the European label because it wasn't part of the initial study design? Probably, even though the benefit was seen with regard to disease-free survival in all patients, because the overall survival wasn't telling at the time, which is good. Patients have a very good outcome, even in this high-risk population, and we hope it's going to stay that way for a very long time. But from an FDA perspective, there was no overall survival benefit, and they could already see a hazard ratio below 1 for overall survival in the high Ki-67 group. And the reason that is because, like Dr. Johnston showed nicely on Tuesday, because Ki-67, even in this clinically very high-risk group, is still a very good prognostic factor with the centralized cutoff of 20%. And you can see here it's prognostic, but it's by no means predictive of abemaciclib benefit. And now we see still immature overall survival data, but for the first time, the hazard ratio also in the ITT population to be below 1. So with that, what's the role of Ki-67 in clinical decision-making? It's not a sole factor. You need to use it together with tumor burden and biology, and there is no single Ki-67 cutoff value that you can use for clinical decision-making to forego chemotherapy, for example. But we know from data in thousands of patients from the UK, from the US, and from our studies in Germany that the short endocrine therapy and then looking in the surgical specimen for a Ki-67 of 10% or lower, which we call endocrine response, is a very robust parameter across countries, across centers, whatever, and it has validated clinical utility, and it's been used in drug development for a long time. And lastly, I personally think, and Torsten agrees with me, that the Ki-67 cutoff of 20%, which is prognostic in the Monarch E study but not predictive, is probably going to go away in the FDA label with the maturing outcome data. Thank you very much.
Thank you, Dr. Harbeck and Dr. Nielsen. So in the interest of time, there's just time for maybe 1 or 2 questions with just brief answers. Anybody has any questions? While somebody comes up, I think, Dr. Harbeck, I just had one question. If you could comment on the utility of endocrine response assessment for using Ki-67 decline with newer novel endocrine agents that are currently in development, since they have slightly differing mechanisms of action, so if you can comment on that.
I think this Ki-67 decline has been used in drug development for endocrine agents for a while, and we've seen recently all these SERDs that are actually still being tested in the clinic. They did have a better proliferation suppression than AIs in short preclinical trials. So it's still being used and in drug development. That's why I think it's about prime time to use it also for the benefit of our patients.
Thank you. Thank you all today for coming in, and to our virtual attendees as well. And thank you to all our presenters.
Thank you so much for being so